Good afternoon, everyone. We're going to start at 12:05 p.m. Thank you.
Okay, good afternoon, folks. Andy Reese, the Director of Department on Disability Services. Um, so we did not receive questions today, but we do have a few issues that we're going to talk about. And of course, we will take any questions that people want to type in the chat today, consistent with our sort of ongoing learning of ways to use technology to maintain contact with folks. We now have the control that we wanted in terms of people not sort of breaking through and having issues with the sound, while at the same time allowing for people to type their questions in chat that can be shared with the whole group. So we've combined the two formats, the two platforms within WebEx that we hope will work for people. So you should be able to type your questions directly in and we will see them rather than having to forward them on. we'll see how that works today. And as I said, it continues to be a work in progress, and we continue to improve as we are able. So as of today, 242 people have tested positive for COVID-19 who are supported by DDA. That's just one more person added since last week. We currently do have 2 people in the hospital. We have lost 33 people that who have had COVID. That still does include, as I'd mentioned before, 5 people who died sometime after actually recovering from COVID, and the determination of whether their death was actually COVID related will be made by OCME, and they'll advise us of that once their report is complete. Of the 242, 127 have not required inpatient care for COVID-19, and 80 have been hospitalized and since discharged. The people who have tested positive for COVID-19 include 105 people in supported living placements, 86 who are in intermediate care facilities, 27 in residential habilitation, 18 who've been in natural homes, 4 in host homes, and 2 in a nursing home. I think we had talked about this. We have been coordinating much more. We've been working closely with DC Health based on some recent legislation passed and new rules to coordinate closely on the reporting of staff. And so there's a bit of a jump in that number now, but we think that we're getting to a much more complete number and ensuring that we have a record of all staff who have tested positive. So to date, and this number may move a little bit, but to date, there have been 305 people, which includes actually 16 people who work at more than one provider. 15 of those people work at 2, and 1 of them worked at 4 different provider agencies. And unfortunately, we have lost 9 staff to COVID-19. In working with DC Health to gather all the information from providers, there was 1 person who had died early on who had not previously been reported. As people may recall, we've been reporting 6. So there was 1 that had not been reported, and sadly, in this past week, providers have lost 2 staff. So we have with us today Donald Clark, who has been working for the agency on the electronic visit verification, which is supposed to go into effect January 1. We've had presentations by DHCF and DDS for providers. We had one for DDS staff. And so Donald's here today to talk to the community about what electronic visit verification will look like when it gets implemented.
Thank you, Director Reese. May I have sharing rights?
Sure. Give me 1 second. You should have them now, Donald.
All righty, thank you. Good afternoon, everyone. My name is Donald Clark. I'm actually a program development specialist with the Department on Disability Services. I wanted to take the time today to really reach out to the community and inform them of actually a project that has been going on prior to COVID and that continues to go on called electronic visit verification. This is a project that is led by the DC Department of Healthcare Finance with the involvement of DDS. And just for a disclaimer before we kick off, electronic visit verification. I'll be referencing it as EVV. I'm sorry. Loading view. I'm sorry. I'm getting some instruction here on. I'm sorry, can someone instruct me how to do floating view?
I'm sorry, repeat that?
Okay, it's not for me. I read a chat. I thought they were instructing me to put an ASL on floating view. I'm sorry. To continue on, yeah, so EVV is not necessarily a something that's required or has been required by DHCF or DDS. This is actually passed through a federal law that requires for all states who are funding personal care services through Medicaid that occur in a person's home must be in compliance with EVV. And what EVV really aims to do is to ensure that services are being delivered to people who actually need them, to cut down on fraud, waste, and abuse. How it does that for states is that states have to implement a system, electronic system, to capture and document the precise times that services begins and ends in a person's home. So as I stated, it starts at the start of the visit, and then the DSP has to actually check out in the system at the end of the visit. But during the course of that process, there are core pieces of information that is being captured during that visit. For starters, types of services performed, which in this case would be services under the IDD waiver that are considered personal care services. It will also capture information on the individual who's receiving the services, as well as the date of the service, location, which in this instance would be in the home, to verify that location, and also document that the person, associate the person that is receiving the services. So how the district is really doing this is two ways to actually capture this information and then communicate it to the EVV system for the district. One way is through an app, through the DSP's mobile cell phone. And then another way that DSPs can check in is by calling in through landline. There will be a number provided. We call into that number. It goes to the EVV system and stamps the information that was presented on the previous slide. And the same thing happens at the end of the visit. The system that the district has, the developer of the system is called SanData. They will be creating the business rules for the system and helping the district deploy it. So the question, $1 million question, what DDA services are actually required to be in compliance with EVV? Well, obviously personal care services that are Medicaid funded, but also some IDD waiver services such as supported living periodic with and without transportation, in-home supports, respite, and in particular, respite that is provided in the person's home. And at the bottom is really a disclaimer that if you don't see a host of services here that we know that are in the IDD waiver, that is because they do not share an element of personal care services where the DSP goes to the home and provides supports around some of the set of ADL skills, or those settings are where personal care or DSPs are in that setting 24/7 around the clock, which at that point is not technically deemed a home visit to the person's home. So timeline and communication updates. We really kicked this off, DHCF kicked this project off in November 2019. We have made some traction with business rules as far as the flow and how the system will work. And now we're moving on with the actual system design based off of those business rules. We are projecting to go live in December 2020. And prior to that, deploy training to providers who provide those set of services in November. This is just, I want to leave everyone this information. The EVV website has been launched by DHCF. That is your source to go find out about updates and information about the EVV project. In addition to that, we also have a EVV email for questions, so you can receive answers from DHCF or DDS. That is evvinfo@dc.gov. And also a phone number, 202-905-4388, where same thing, you can ask questions there. The website also does host a live document of frequently asked questions that will continuously be updated. One other thing I wanted to share in closing is that I know this is for the community, but if there are also providers in this meeting, I urge providers to make sure who are required to be in compliance with EVV based off of those set of services and supports, that you make sure that you register at evvinfo@dc.gov so you can get the recent updates and also get invites to monthly stakeholder meetings for providers, so you're aware of requirements moving forward with the project. Before we move on to questions and answers, I'm also accompanied by DHCF's Lewis Spence-Smith, and from SANDATA, the developer of the EVV system, I have Kim Jefferson and Andrea Shelton. Again, we don't want to take up too much time. I know there's a lot to cover today, so please also feel free to send, questions through email, but just wanted to open up for questions. And if Ms. Jefferson or Lewis, if I missed any pertinent information, please feel free to add on.
Hey, so this is Lewis Spence-Smith with Department of Healthcare Finance. I'm the contract administrator for EVV. We just want to encourage you all, if you have any questions, if there's any information that you don't necessarily understand, you can always go to our webpage, which is dhcf.dc.gov, and then it's /EVV. Or you can just search EVVDC and it should bring you up to our webpage. Or you can shoot your questions via email to evvinfo@dc.gov. We can put that link in the chat as well. So it's evvinfo@dc.gov. To have any questions, if you're a provider and you want to learn more about the system, you can always reach out to that email address. And we just got a question regarding if providers want to utilize their own EVV system. If you're utilizing your own EVV system, that means you are not using the system that is provided by the Department of Healthcare Finance. You are welcome to utilize your own system. However, you have to reach out to DHCF and SANDATA just to let them know that you'll be exercising that option. That being said, any costs incurred for you utilizing your own system, you all would have to be responsible for. However, the EVV system that's provided by DHCF with SANDATA is covered by the district.
And just to add on to that, we really do urge you to go to the EVV info website and be mindful that there are monthly stakeholder meetings that take place the third Monday of every month, 11 to 12 o'clock. Very important, for example, in reference to alternative EVV systems and, timeline and deadlines to request to connect with SANDATA to make sure that your system has everything it needs to transfer that information over.
Okay, thank you, Donald. And Donald will still be with us, so if people have questions, please feel free to type them in the chat and we'll call him back to answer those questions for you. Next, I just wanted to let people know that in fact, finally, the amendment to our Appendix K was approved by CMS yesterday. It is posted on CMS's website, and it can be found at this address. For people at a computer, it's easy enough to cut and paste that. But if you go to the CMS website, you can find our current, there are 2 postings there, so make sure you're looking at the amended version. We had gone over what's in it previously, and so substantively, there were no changes. Except that, as I had spoken about before, the issue regarding retainer payments, which is that retainer payments are for 90 days of service, which was a change because when we had done our original Appendix K, we had retainer payments were for 18 days, but they could be for multiple periods with no limit. CMS came back and said there had to be a limit, and so that amendment in the Appendix K was required by CMS. And so what it provides for now is 90 days of service. We've been talking about 18 weeks because if you do 5 days a week, that is 90 days of service. But the guidance from CMS is that retainer payments can be paid for 90 days of service, whether that's 1 a week or 5 a week. In whatever combination you do them, we can provide support through retainer payments for 90 days of service. There are also some requirements for retainer payments that you'll see in the revised Appendix K, some attestations to be made, indicating that the funds received through the retainer payment are not duplicating any other funds received, either through CARES Act funds or PPP, any other funds that you may have received. That you can't receive funds from 2 different places for the same thing. And there just needs to be an attestation included to confirm that fact. We made some adjustments, as people know, that you will see the companion rates in the revised Appendix K. There's a separate rate for companion 1-to-1, 1-to-2, and 1-to-3. We will be sending out this afternoon a transmittal to all providers. So what I'd invite you to do is review that transmittal, and if you have questions, you could send those questions in and we can address them. We can decide whether, depending on the volume of questions, whether we would do it during this time next week or set up a separate time next week so that we adequately address any questions that people have. But I believe that the transmittal that's going out provides a thorough description of everything in the Appendix K and how to submit claims under the Appendix K. Now, that, I believe, is all that we had today. So if people have questions, please feel free to enter those in the chat. So I see 2 questions here. When will CPAC be available again? And so I'm confused. CPAC being Community Participation Assessment and Questionnaire, it is available on our website. We have the process is that the day providers have submitted, day providers are submitting their plans. 9 have submitted plans, which they are getting feedback on now. As soon as there are approved plans, they will be having the interdisciplinary team meetings to discuss implementing day services discussed in the CPAC. And so they're available now. I'm not sure who this question is coming from. I see the person, but I don't know if you're representing a provider agency, because they are available on our website. It's a form that's available in MCIS, and those should be completed. Once they're completed, the provider then commits them to MCIS, and then the service coordinator will have an IDT meeting. I will say, since some have been completed, and people did have regularly scheduled IDT meetings, some of these have already been considered, and they're discussing the services that will go into place, and those will go into place as soon as the day program plans are ready. So I see this comment, many service coordinators are saying that the CPAC is on hold and are refusing to complete them. It's not, in most cases, the service coordinator who completes them. It's providers who complete them and commit them. For folks who are in a natural home, it may be a service coordinator, and the service coordinator then, by complete them, you may mean move on to the next phase, which is to then have the IDT meeting, which that meeting is scheduled as soon as it's clear that the day program is ready to initiate services. So once we have the approved day program reopening plan from the particular day provider that had been involved with that person, then the IDT meeting would be scheduled. So, yes, that is correct. That service coordinators are holding off on IDT meetings until the plans are approved. And maybe Kirk, you could speak to the review of the day program plans.
Sure. So we've received about 10 day reopening plans from day providers, and we are currently in the process of reviewing them. So there's a pretty much a committee that reviews them. It's I chair the committee. It's made up of the QRS supervisors, the QRS, and our health and wellness team. And so we're currently actively going through them. So we expect the first approvals to go out next week. We have reached out to providers for feedback and additional information if we had questions. And so we are trying to provide as much technical assistance as we can to get providers to an approval. As I said, early next week is the estimated time that we'll start approving.
So the other piece of the having those IDT meetings is for people who are receiving employment readiness services and may want to continue those, but the provider could be doing them remotely. The service coordinator will be inviting a VR counselor to participate in that meeting. And Daryl Evans is with us today, and I'm hoping can unmute and can talk about the training that's being provided to those VR counselors and how they will be coordinating with DDA in order to put in place either job readiness or discovery or potentially supported employment job coaching services for people who currently get employment readiness through the waiver. Daryl?
Thank you, Director Reese. Can you guys hear me?
Yes.
Good. Thank you again for letting me come in and kind of chime in. I really wanted to give an update to the DDA RSA job readiness process. Director Reese has covered this in several of the meetings, but I really wanted to kind of talk about some timelines. We have developed the internal process for our RSA and DDA teams. We're going to have the in-house training for both sets of administrations the week of August 31st through September 4th. And then we look to have a potential rollout for the providers to start providing the services the week of September 7th through the 11th. Now, I realize that that Monday is Labor Day, but we still look to try to move this forward. I want to touch on some of the highlights of this, and so that everyone is very clear that we're very, very conscientious of really tamping down barriers for our consumers that are going to work inside of these employment readiness and job readiness avenues. So when we have, and I'm just going to touch on some of the highlights. So for the new referrals that would come from DDA to RSA, if the person is receiving DDA services and they express an interest in employment during the annual ISP update, then what we'll do is when we get the referral from the service coordinator, we will actually have all VR counselors mandated to be at the IDT meetings. Prior to the meetings, they will get the community participation assessment and questionnaire, and they will have all of the information that's pertinent to this consumer before they walk into the IDT meeting. Additionally, for the new consumers, we will be authorizing discovery that should generate the PPP document that the VR counselor will then be able to use in drafting the IPE. We've eliminated the precipice of the 90-day advent to create an IPE, because now that these folks, our VR counselors, are mandated to be in the IDT meetings and closely coordinating with the service coordination team and the provider team, we're looking at 1 to 3 days to get that turned around. So we're really talking about getting these folks expedited into the job readiness training and then really monitoring it. Additionally, we've now ask our VR counselors to check in weekly with the providers, knowing full well that, you know, there's 12 days of job readiness within a 6-week period that can take place. We're well aware of that, but I have instructed them that I want them to check in weekly, because again, the whole point of us opening up this job readiness advent is to ensure that these consumers are having gainful employment opportunities. That's what this is about. We don't want people to linger in job readiness for 6 months, 12 months, 2 years. That's not what this is about. This is about really doing some counseling and guidance and moving folks into employment. So that's what the process is really standing up. And for our consumers that are already working with RSA, this really is a 1 to 3 business day advent. This is simply having an IDT meeting with service coordination and the provider and the supports for the person, and talking about updating the IPE goal and then generating authorizations almost simultaneously to get the provider moving in that direction. So again, this really is about eliminating barriers, being very conscientious of time, having good follow-up and good direction in order to move folks into successful employment. Providers, I would just implore you again to go back to your HCAs and look at section C, 0.5, 0.2, 0.6, 0.6, 0.1, 0.5, and we will send something out. My idea of this is, after we have the trainings over the next week, is for next week's meeting to have an FAQ sheet that will list kind of what are the nuances in this process, kind of some of the highlights out of your HCA that you really should be paying attention to as providers, so that we're very time sensitive, how you would send your authorizations through, how they would be approved, who would be reviewing them, if we need to approve additional job readiness because the person needs more supports, how that would work. So we're looking to have a document for you all next week that we can share out with you that will just have some FAQs that may kind of help guide the process. But we really are honed in on this. I want to also let the providers know, please start thinking about what your curriculums and your job readiness plans are going to be, especially for those of you that have consumers that are already in your charge that you know are going to want to jump into this process. Those things are really going to expedite they'll expedite the authorizations once we get them in. After once we get them in on our side, we'll be able to really expedite the process. And so I can't implore enough to you the removal of barriers to the extent we can, and really expedited timeframes and more engagement and collaboration between DDA, RSA, and the providers, so that this is a very seamless process for our folks and that our consumers are moved into employment. This shouldn't be a day event for them. This shouldn't be something for them to do for the day. This really should be developing soft skills, resume writing, all of the things that lead to employment. That's what these outcomes should be. So I know that's kind of a mouthful. I'm going to put my contact information, my email, my phone numbers into the chat box, and you feel free to email me any direct questions that you may have. And again, we will add those to the FAQ document, and we look to present that out to you next week. Director Reese, are there other things that you'd like me to cover?
I just want to emphasize a couple of things. One is I want to remind people when our waiver was renewed in November 2017, it included a limitation on employment readiness of 2 years, so that, beginning with the person's next ISP, they could only get 2 years of service, which for a number of people, they may have been hitting that limitation recently. And so folks who have exhausted their employment readiness hours really need to be talking about, what the next step is for them. We're not going to be shifting them over to job readiness as a way of continuing employment readiness. The idea in our amendment to the waiver was you don't get ready to go to work for that long. And, we've had people, I mean, what I usually say to people is that the best job readiness training is a job. And so, so there may be people who have hit their 2-year limit, and the service coordinators will be looking at that. The other thing, as a reminder, employment readiness is a group service. So what you're looking at here is how you're going to do job readiness, which is job readiness group. And the rate for RSA is paid for groups, it says between 2 and 12, I think is the number in the human care agreement. And so, as Daryl said, be thinking about your curriculum. RSA, because they are focused on employment, they're going to be very focused on making sure that the skills this person is learning is working toward a job, working toward becoming employed, not that this is a more enjoyable way for the person to spend their days. So they really are going to be looking at the curriculum, monitoring people's progress, and moving them toward employment. So there was a question. Are there any other questions about that? I do see for day providers that want to provide employment readiness services, do we need to prompt the service coordinator to make sure they're inviting a VR counselor? So the way that it should be working is anyone who has employment readiness in their current as a service currently that they were receiving and are eligible to continue receiving, in those instances, they will invite the VR counselor. And the service coordinators have been advised of this. Someone asked a question about reimbursement for overtime paid. It says during COVID-19 positive lockdown. So just to clarify, in our Appendix K, we have what's referred to as a quarantine rate. And so if a home is quarantined based on a person testing positive or there being an exposure, and people have to self-quarantine, then there is an enhanced rate that is paid. And there are instructions. There were actually instructions in the initially approved Appendix K that have not changed in this amendment. Any payment for overtime in quarantined homes, those claims just for the overtime piece are submitted to DDS, and maybe Winslow can provide some more specific information about that process.
Yes, Director Reese. We have had at least 4 providers who have followed the process that was outlined in the initial Appendix K with regard to this issue. The Appendix K transmittal included the instructions on how to submit, and the transmittal that should be going out hopefully this afternoon will also include the instructions on how to submit. I wasn't certain whether the question was directed to a quarantine home or not, because when people use the term lockdown, which we've never really locked down, but the overtime submission process is specific to homes, as your director stated, that have a positive COVID case or have a positive exposure. And the quarantine is implemented, and the process spells out what actually needs to be submitted. It's too much to post in the text chat box, but we will be sending it out again today. That's it.
Thank you.
So Director Reese, I do not see any further questions. Oh, one just came in.
I'm giving people a couple minutes.
A couple just came in.
There was a question, I'm sorry, and I overlooked that from before. There was a question regarding the TME testing. Hold on, I had to scroll back up because I had read that, and then I'm very sorry that I forgot that it was up there. We're continuing to have difficulty with TME exams being delayed or canceled. And we do have some folks from DC Health with us today. I don't know if this is a DC Health issue, and I don't know if it's a DC Health issue that the folks we have from DC Health today can answer, but
so unfortunately, Director Reese, not many folks from DC Health were able to join. They had prior obligations. So this is one of the questions that I will take back to them and send out an update as soon as I receive instructions and or an answer.
So can I just ask for a follow-up? Who's delaying or canceling the exam? Like, who administers this exam that's being delayed or canceled? Oh, I'm very sorry. I'm usually better at not doing that. Trained medication employees, TME. So this is a question from the Board of Nursing administers the exam, is what I'm reading here.
They do, Director Reese, and Ms. Hampton, who is the executive director of the board, spoke to this issue several weeks ago. There were recommendations from providers that the testing should be, for lack of a better word, sent out to a newer vendor, because I believe providers were having specific challenges with the current vendor who administers the test.
So I see a question. When does DDS estimate that the first day program will reopen? I'd have to talk to day program providers. I do know that some day program providers have been providing some services. So, and keep in mind that some of those day services, including supported employment, have been provided all along. And so when will some of our facility-based programs reopen? I'd expect fairly soon, but let me also say, because I always sort of like to include this caution for people. Whenever I read a question like that, I get very concerned that someone is expecting that at some point in the near future, that day services are going to look like they looked in January. They are not. We have, when you look at how, there are a number of factors that need to be considered, including, given the higher risk of serious outcomes if they were to contract COVID-19, there are a number of people who are going to significantly reduce interaction with any more people than necessary. So, they're not going to be involved in a lot of different programming, perhaps. Ideally, what that will mean is that the very limited number of people they're working with in their home will work with them on the different skills that they are working on, or will, keep them engaged in what's important to them and what's important for them in terms of, continuing whatever skill development they might have been getting had they been going to a day program. So, there's that population of people. Any population of people, there's a limit on the number of people who could be in a day program, even if all of those people were not folks who were at higher risk for a serious outcome from COVID. And so, the capacity of the day programs is going to be reduced. One of the things we talked about this week also is, as we look at some of the day programs that are doing community-based activities, they're likely going to need to look at perhaps shifting service provision, perhaps to IDS 1 to 2 rather than day program community-based, because being in the community with 4 people in a safe manner sounds like it's difficult to impossible. People also used to spend a great deal of time in the community, and for all of us, we're spending less time in the community because there are less things to do, and there are fewer things that any of us, perhaps, regardless of our risk factor for contracting or the risk of having serious consequences from COVID, that we're all making choices about the kinds of activities we engage in to minimize our own risk. And the people we support will be making those same kinds of decisions. So, what this really will require is for our day providers to be very creative, for all of our providers to be flexible, to be working together, to figure out ways to identify what the need, when we have our interdisciplinary team meetings, to really talk about what are the activities in which the person wants to be engaged and how can that happen in the safest manner possible. And so having a real conversation about which aspects of that could the day provider do, which may be a shift from how they did it before, which aspects perhaps will the residential provider need to continue. But as I say, when I hear when is a day program reopening, I get nervous that people think that we're going to turn back the clock to January at some point. It will be a long time before things look the way they looked in January. So how many DDA funded residential placements are currently quarantined? So when I looked at the places where we had, so there's two different things I look at in considering that question. And one is folks who've had an exposure, and there are just 2 homes currently where there are folks who have had an exposure, but we also have 15 or 16 people, right, in 15 different placements was it, who have not completely recovered from COVID. Now, a couple of those folks are in the hospital, so their home wouldn't be quarantined at this time. But then some of them are in homes that then they would be isolated in the home. But in terms of, for exposures, we just have 2 homes where there's a quarantine, and then we have other folks who are isolated in various different ways. Because in some circumstances, the people are then if they can't be isolated safely in a home, they're moved to another placement. And as I said, we do have 2 people who are currently in the hospital. Can you please clarify for day providers the attestation of the billing for retainer payments, how that applies against CARES Act funds through the PPP and the SBA EIDL? I don't know any of those, so all I can do is read them. I'm assuming Small Business Administration, and I know what PPP is, but I never remember what it stands for. I'm sorry. That may have been applied for or received. So the specifics of the attestation is included in the amended Appendix K that is on the website that I provided earlier. So I'd rather you just go and read that because it gives exactly what is needed. And the transmittal we're sending also includes exactly what you need to do. Just to clarify, the takeaway from it is you can't get money from more than one source for the same thing. So to the extent you have used the Paycheck Protection Program to pay staff, keep in mind that, for example, our retainer payments included everything except direct care staff. So if you used PPP to pay for staff other than direct care staff and you get a retainer payment, you need to remember that the retainer payment does include the administrative costs and the indirect staff. And so you do need to pay attention to what each of these things is funding, because as I said, just as a basic principle, you can't get money from more than one source for the same purpose.
And Director Reese adds to that, that also includes the HHS Provider Relief Fund. So that's another, just to make sure that's also applicable to that as well. And as well as the Economic Injury Disaster Loans, so EIDLs. So all those funding sources apply.
It does, it's a challenge in terms of accounting, but it is sort of basic common sense that you can't get 2 different sources to pay the same bill, because one of them is going to come back and want their money back. Okay, I don't see any additional questions. We're 4 minutes from the end. We can end 4 minutes early, unless people do. Now it's 3 minutes early, unless people do have any additional questions. As I said, we will be sending out the transmittal this afternoon. Please get your questions into us by Wednesday so that we can make sure that we answer your questions fully. It would be much more effective than holding them and typing them in the chat box next Friday. So if you're able to review the transmittal as well as the CDC guidance, the CDC website where it has our Appendix K, and then give us any questions that you had. I see here it says Lisa Brace has asked a question, and maybe I have missed it.
No, so if people have questions, they need to make sure they click to everyone because not.
Oh.
So yeah, so that went to all attendees. So that didn't come to us panelists or hosts. So you have to make sure
this went to all of you.
Yeah,
So,
it went to all
maybe
attendees.
one of you could answer it. So Lisa, if you wouldn't mind sending that to everyone or to panelists, just so I can see it. As I said, we continue to figure out our technology to do this, hopefully more effectively each time. Oh. Okay, so there is this says questionable new guidance from the CDC as it relates to testing for individuals exposed to COVID-19 but asymptomatic. How is DDS or DC Health addressing this? We have guidance that we've written up that's being reviewed by DC Health. So one of the, I can cover what the CDC guidance was and the parts of it that so I heard news reports today interpreting it one way, but I'll also tell you the other interpretation, which I did talk about, I believe, last week. When Daryl Hawkins presented to people, she also talked about that some of the guidance from the CDC is encouraging shifts in their recommendations from being testing based to being symptom based. In that what their guidance says is that there may be people who continue to shed enough virus that they test positive but are no longer infectious, and therefore the time for it used to be that their guidance was there have to be 2 negative tests at least 24 hours apart in order for a person to be considered having recovered from COVID-19 and removed from isolation. And people may remember back in like March, the man who had been on a cruise and was staying in a hotel out in LA while his wife returned to work, and he was being tested every couple of days and was never getting his negative tests, and his wife was running the business while he was living in a hotel room. So the CDC has updated that guidance to include a symptom-based recommendation and to include recommendations about for people who are asymptomatic. And the way that, and like I say, it's being reviewed by DC Health. So once we have our final guidance, we'll share it with people. But the way it's being interpreted by us is not, what I heard on the news this morning is that they're saying if a person is asymptomatic, they shouldn't be tested. What I have, that they should only be tested if they have symptoms. So if a person has had an exposure The guidance that we have so far has been saying that regardless of a test result, the person should self-quarantine for 14 days. And so it lessens the reliance on that test result as a measure of whether the person, of what the person's actions should be to protect other people. And so, you know, the district has not changed its guidance in that regard that I'm aware of, but as we get the final guidance, we'll let you know. But what I will say is that, you know, I know I heard this morning sort of a different take on pretty much the same thing I had read from the CDC website, which was, and very clear guidance from DC Health and from the mayor. If you have had a direct contact exposure with a person who tested positive for COVID-19, you should self-quarantine for 14 days. You may get a test, but even if you get a test and that test result is negative, you should remain quarantined for those 14 days. Does DDS or DC Health utilize the new Abbott COVID test? So DDS doesn't test people. And I don't know if someone from DC Health can answer that question.
Yeah, Director Reese, I don't think there's anyone from DC Health on the call in a moment.
Okay. And I'm not sure the significance of the new Abbott COVID test. Is this the rapid test that you're referring to? I don't. Okay, yeah, so I am not certain the extent to which DC Health may be using rapid testing in any of their test sites. We can get an update from them about the kinds of tests they use. I don't believe they're using rapid testing, but I'm not certain. They are reporting that their time frame for returning test results has come down. Dr. Nesbitt reported that to me, that they have gotten better turnaround times. At the time, she said the average was a 3-day turnaround for the DC public testing sites.
So I think, Director Reese, we're not out of time. It's 1:05 p.m.
Okay, so apparently as I was describing our Appendix K, I kept going back and forth between referring to CMS and CDC. So I'm just going to paste once again the website information so that people can go to the CMS, the Centers for Medicare and Medicaid Services website, and see our current Appendix K. And we are finished, so we do not need a change in interpreter. So we will talk to everyone next week. Have a great weekend. Thank you, and take care of yourselves. Thanks.
I will leave this up running for a few minutes just so people can get the link if they need it.